Hi, my name's Chris. I just took COMLEX Level 3, and I'm making a video series of high-yield topics that you will probably see on exam day. I don't think there's a lot of great resources for Level 3, so I hope this is helpful to somebody. Let's jump right in. A 45-year-old male presents with a 3-month history of diminished ability to swallow solids and liquids. The physical exam is significant for halitosis. He does not smoke, drinks 2 to 4 beers a week socially. Barium study is performed. Which of the following is the next best step in management? Let's go through the choices. Choice A, 24-hour pH monitoring. Wrong answer. This is used to confirm a diagnosis of GERD. I don't think it's ever going to be the correct answer on a COMLEX exam. I've never seen it, not even on practice exams or test banks. So recall that GERD's unique. The best initial test is also the best initial treatment. You'd start with a 2-week trial of PPIs or H2 blockers. 24-hour pH monitoring could be used if you still suspect GERD after the PPI trial fails. In this question, our patient isn't presenting with GERD, or if they are, it's an alarm symptom. The complaint here is dysphagia, and that's a late symptom of GERD, and it requires a different approach. Choice A is wrong. Choice B, EGD. EGD is wrong. You need to look at the barium swallow included. Now, it sounds simple now, but these are the types of things that students tend to freak out on and miss on exam day. EGD would be the initial step for new onset dysphagia to rule out malignancy. It would be the correct answer if that picture weren't included. When you have symptoms of heartburn or reflux or GERD, as well as alarm symptoms, so what are alarm symptoms? GI bleeding that presents as black tarry stools, hematemesis, unexplained weight loss. It goes without saying. New onset dysphagia or new onset symptoms in patients that are older than 60. When I said dysphagia, I just meant to say new onset heartburn or reflux in patients over 60. And I think it's noteworthy to pause and just spend a moment to harp on that. That's sort of how COMLEX asks their questions. So if they want to give you a staple condition like GERD, they expect you to know that. And I think there will be some nuance. They may give you a very straightforward presentation, and it's your job to stop and pause and make sure you're not missing something. In this case, if you have a patient over 60 with a very straightforward presentation of gastroesophageal reflux disease, you may be tempted to pick a 2-week trial of PPIs, but COMLEX wants you to pick EGD in that case because new onset symptoms in an older age, older than 60, is an alarm symptom. In contrast, if they want you to recognize GERD, they're not going to give you necessarily the most classic presentation. So remember nocturnal cough, pneumonitis, recurrent aspiration pneumonia, even postnasal drip. Those are all super high yield associations for GERD. So postnasal drip, just remember, hey, stomach acid travels up the esophagus into the throat, irritates the respiratory airways, and triggers some mucus production. Bottom line, we're not talking about GERD or malignancy in this question, so that's the wrong answer. Choice C, NG2, wrong answer. This would be the correct answer with tracheoesophageal fistula or choanal atresia, usually neonate type questions. So tracheoesophageal question stem is going to be coughing up milk with the initial feed. Choanal atresia, that means the nasal passages aren't patent and you can't pass an NG tube. Presentation is going to sound like this. Baby turns blue when they're feeding. They become pink when they unlatch and they start to cry. In this case, it's not related. Wrong answer. Choice D, manometry. This is the correct answer. It's the gold standard confirmatory test for diagnosing achalasia. It's the best next step here. So recall mechanism going into pathophysiology. You have increased lower esophageal sphincter tone due to the loss of the myenteric plexus, also called the Auerbach plexus. Normally, you have nitric oxide secreting neurons there. If they're absent, you're going to have increased tone. I bring that up because that's a neurogenic achalasia. and you'll have simultaneous dysphagia to solids and liquids, and that's important. That's probably the take-home part of the video. When you compare it to malignancy, you're going to have progressive dysphagia from solids progressing to liquids. Remember, adenocarcinoma is associated with long-standing history of GERD. It's going to affect the lower third of the esophagus. Adenocarcinoma is the most common cause of esophageal carcinoma in the United States. Squamous cell carcinoma, that's associated with long-standing history of smoking and drinking. That affects the upper portion of the esophagus, and that's the most common cause of esophageal carcinoma worldwide. Malignancy, progressive dysphagia, and neurogenic dysphagia, it's simultaneous dysphagia to solids and liquids. Choice E, wrapping up, surgical consult is the wrong answer. That would be the definitive treatment if that were what we were asking. You could do something like a pneumatic dilation or a Heller myotomy, but you have to make a formal diagnosis, and that formal diagnosis requires manometry before you move to a definitive and invasive treatment. So that's it. I hope it's helpful, and thank you for watching. Please, please, please like. It will encourage me to make more videos. Good luck studying.